شكرا دكتور رضا على المحاضرة الرائعة جدا. دلوقتي أستاذنا الفاضل أستاذ دكتور علي سليمان هيقدم لنا. بشكر الأستاذ الدكتور رضا على هذه المحاضرة very illustrative and highly scientific. بس قبل المحاضرة اللي جاية بحب بس أشكر اللجنة المنظمة لهذا المؤتمر الرائع، أستاذة الدكتورة سالي الخولي، الأستاذ الدكتور حاتم سمير، على التنظيم الرائع لهذا المؤتمر وعلى دعوتهم لي أكون chairperson وسط كوكبة من السادة الأساتذة المميزين على مستوى الجمهورية. والآن أحمد جابر.
Disclosures for conflict. I'm going to start by defining drug-resistant epilepsy, speak to the impact on development and quality of life, and the importance of surgical intervention, including specific consideration for medical intractability in epilepsy is defined when we have not been able to control epilepsy with at least 2 or more appropriately selected and adequately tried anti-seizure medications. There are critical factors to consider in children who have intractable epilepsy, including the age of onset, the duration of epilepsy, seizure frequency, type, and the severity. For example, convulsive seizures and convulsive epilepsy carries higher morbidity and mortality than, say, absence seizures. The impact that those seizures have on daily functioning, development, and learning, as well as the presence of adequate family and social support. In terms of the pre-surgical evaluation for children with intractable epilepsy, the cornerstone is really the clinical assessment. And that starts with detailed history, neurological history, and detailed seizure semiology. The various types of seizures, their frequency, their duration, and whether there are any triggers or any warnings prior to the seizure. We also want to evaluate the development from a neuropsychological standpoint, including aspects of memory and learning. And finally, a family history is essential for those situations to probe if there is any underlying genetic etiology as well. In terms of diagnostic studies, the 3 key diagnostic evaluations, in my view, would be a good quality video EEG monitoring with good ictal assessment during seizure. The interaction with the child during the seizure can yield important information in terms of localization. A high resolution MRI is also important because it can highlight any lesions that are present, and of course a neuropsychological evaluation that would look at aspect of language and memory. So the 3 key things in my view would be video EEG, MRI, and neuropsychological evaluation. Now, in the presence of further advanced studies, we can certainly obtain a PET scan, a SPECT, a functional MRI, an MEG, and genetic testing, but these are not universally available at every center. Speaking of surgical candidacy. What would make a child a favorable candidate for epilepsy surgery? If there is a focal lesion on imaging, that would be one. If there is a clear, consistent seizure semiology, and I think this is probably the key factor. If there is one unique semiology or a spectrum of semiologies that are on a continuum where we believe they all fall into a discrete focal area, such as in mesial temporal lobe, where there is an aura of fear, a sense of impending doom, tachycardia, autonomic symptoms proceeding to secondary generalization that would indicate potential unique localization. So having discrete and stereotype semiology is important. If the EEG and the imaging findings are concordant, this would lead to favorable outcome as well. And the final point is if there is a preserved cognitive function, because that tends to have a better prognostic value for the future. There are some relative contraindications, including the presence of multiple independent seizure foci, although it's not an absolute contraindication. We have operated on children who have multiple seizure foci, targeting the more disabling and debilitating seizure types. If there is a history of severe developmental delay, that can potentially be a contraindication, as it may not, surgery may actually not lead to significant advantage from a developmental standpoint. Add to that the potential high risk associated with epilepsies emanating from the eloquent cortex, such as the motor system. So surgery on the primary motor area can be a high stake and can be a relative contraindication. And the presence of significant medical comorbidities that potentially would preclude any surgical intervention due to the high risk of morbidity in the setting of any operation. We have to bear in mind that adult localization paradigms are not applicable to children because of this evolving pattern of seizure semiology in EEG due to the maturation factors. And the models that we have in the literature are centered around visualization of an area in the brain that has to be removed to render the child seizure free. So despite the advancement in technology, despite the multitude of diagnostics that are available, our seizure freedom outcomes have not really changed over the years, because most of the localization paradigms in general in epilepsy surgery centered around the three issues of good quality video EEG, which includes semiology, neuroimaging, and neuropsychology evaluation. But the children don't always have all these elements. Young children will not be able to participate in neuropsychological evaluation. Sometimes, even with video EEG, the semiology could be very subtle, or EEG changes can be very diffuse. So we have to bear in mind that there are some other factors that we need to consider. We'll touch on those. So what are some of the key considerations in pediatric epilepsy? We can divide those into four key elements. In terms of the anatomy, the dysplastic changes in the brain tends to be somewhat bilateral, and that can hinder the surgical evaluation process. We know that there could be some functional reorganization in dysplastic cortex in young children, and there are some age-related changes that can impact the EEG because of the anatomical changes. As I mentioned earlier, many EEG changes can be non-localizing or could be generalized even in the presence of a unique focal lesion on imaging. Seizure semiology in young children can be a little challenging because they don't have an aura, and there is sometimes an overlap between ictal and physiological behavior. If a child has behavioral arrest, was that because they just stopped what they're doing physiologically, or was it because they are actually having a subtle seizure? And of course, the ictal examination during a seizure can be challenging in young children, and we know that seizure semiology evolves over age. The functional data can be difficult to obtain, especially the neuropsychological evaluation of children. So the children are different in a way because from a clinical presentation, um, it is difficult to ascertain the presence of an aura and loss of awareness in young children. And in those with malformation of cortical development, it could potentially have very high seizure burden. And as far as semiology is concerned, as I mentioned earlier, the clinical onset may not be reliable because of this overlap between physiologic behavior and epileptic or ictal behavior, and the difficulty in performing the exam. The EEG can evolve over time, as is the neuropsychological evaluation. And the etiologies in children would have an impact on the expression of seizures in terms of whether it's related to congenital etiology, perinatal, ischemic, or is it more a malformation cortical development. As far as how do seizures change over time, or what we call the ontogeny of semiology over age, I think for children who are younger than the age of 6, we see more posterior cortex epilepsies as opposed to temporal and frontal in the older kids. And manifestations such as aura, automatism, and secondary generalization tend to be more common in those older than 6 years old, whereas they are less frequently encountered in those younger than 6. In terms of unique aspect for certain epilepsy localization, the semiology of temporal lobe has more early unmarked motor features in younger children, whereas in the older children it tends to be more behavioral arrest with secondary generalization. Whereas in frontal lobe epilepsy, younger children will have epileptic spasms or subtle behavioral changes, whereas in older children we see hyperkinetic seizures and more complex motor semiology. Here is an example of a 7-year-old male who was born at 24 weeks and had intractable epileptic encephalopathy with spike wave activation in sleep, or what we call ESWAS, and developmental delay. He was evaluated at our center for intractable epilepsy, and as you can see from this EEG, he has this diffuse generalized spike wave activation that was persistent actually throughout the night. But here, as you can see in the early part of this EEG page, there is an eye blink. So this is during awake state. We see diffuse and broad generalized epileptiform discharges. That being said, we were able to successfully operate on this child and render him seizure-free. And this is the EEG post-surgery, almost eliminated all the spikes and led to a profound impact on cognitive abilities as well as his behavior. So what are some of the age-specific considerations? In early childhood, we bear in mind the fact that the brain is very plastic, and therefore earlier intervention can actually be extremely valuable and have positive long-term implications, cognitively and developmentally. There are some anesthetic and post-op consideration in this age group as well. As we move more towards adolescence, there are multiple considerations, including things such as planning for education, for college, driving, psychological factor, and their level of compliance with instructions and medications. And we need to look at long-term outcome in this age group because it can have severe impact on their independence as well. So what types of surgical interventions do we have out there? There are resective procedures such as temporal lobectomy or extratemporal resection or lesionectomies, as well as hemispheric disconnection or hemispherectomy. Disconnection procedures such as corpus callosotomy and multiple subfield transection. Ablative surgeries available through the means of laser ablation and radiofrequency ablation. There is also focused ultrasound. There are some other procedures such as the neuromodulatory options, vagal nerve stimulation, responsive neurostimulation, and deep brain stimulation. In terms of the surgical approaches in children, it can be done with a stereotactic guidance, especially when an intracranial electrode, such as stereo electroencephalography. We do use intraoperative monitoring, and we can use awake surgery in appropriate age groups, especially in adolescents who are able to cooperate with such a procedure. And there is obviously the robotic assisted procedures, such as the stereo. There are common pathologies in young children, such as tuberous sclerosis, hypothalamic hamartoma, focal cortical dysplasia, and in general malformation cortical development. Rasmussen's encephalitis is a unique entity that is diagnosed typically in children and is treated with hemispherectomy, as well as low-grade tumors. In terms of the outcomes and the prognosis, seizure freedom rates tends to be higher in young children, especially in the presence of identifiable lesion on brain imaging, and those kids tend to do better in the long term cognitively. There are other measures that we take into consideration, such as quality of life measures. We look at their developmental trajectories, and we do serial neuropsychological evaluation. And the goal is obviously to give those children the best quality of life and allow them to return to school and have as much of a normal life as possible with minimum impact on daily function. We know that from a seizure freedom standpoint, the seizure freedom rates are related to the underlying etiology, and in situations where there is an identifiable lesion, it's the ability to remove the lesion in its entirety in certain situations, such as in cortical dysplasia. Other types of lesion, removing the entire lesion may not be necessary, such as in polymicrogyria. That being said, every child is treated uniquely in the way they present and in the context of the underlying cause of their epilepsy. So I hope in this lecture I was able to convey the message that early surgical intervention is necessary because it can lead to better cognitive outcome in the long term. There are considerations that are age specific, including risks and benefit. We are fortunate to have so many modern techniques that can assist us. Earlier intervention is always associated with better outcomes. The decision making is shared with the family, and the family partnership is a key for the success of epilepsy surgery, and maintaining long-term follow-up for these patients is key for optimal results. Thank you for your attention. Thank you again for the invitation.
Thank you, Dr. Ammar Khidr, for this highly scientific and interesting lecture.